Morning, everyone.
Morning.
Okay. Just wait a second till we have a full crew. Hope everybody had a good weekend.
Yes, thank you.
Cold outside. All right. All right. So this is a tracing obtained on a patient who's post-op night 1 following a stage 1 Norwood for hypoplastic left heart syndrome. And the question is, why might this happen? And what what should we do about this? So why don't we ask Mahmoud? Mahmoud, what do you think's going on here?
Good morning.
Good morning. I should tell you the tracing. This is obviously the ECG on the top, and this is an A line. Sorry, wasn't clear.
So I see a P wave prior to HQRS. And then, so I see a small Q, and then an R and deep S wave, followed by elevated T wave, and then there's a pause. There are like P waves that are not conducted. That's like for about three beats, and then it resumes again. The rhythm seems to be irregular.
So what do we call this? This here, what's going on here? How would you describe this rhythm? So let's pretend this is 1999. I'm at home. I don't have a fax machine. There's no cell phone where you can send a picture. So how do you describe this to me on the phone? This is how it used to be.
I'm not sure if I would say missed beats or like non-conducted P waves.
That would be a better way of saying it, other than missed beats. Yes, I agree.
So the question why it happens, I don't know.
Wait. But what kind of, this is some kind of heart block, right?
Yes.
So is it first degree heart block?
No, it's not.
No, it's not, because in first degree, we see just a very long PR interval, but every P wave is conducted.
Yes.
Usually reflecting either AV nodal or Purkinje disease, usually AV nodal. So is it third degree heart block?
In third degree, there will be no association between the P wave and the QRS.
That's right. There would be complete dissociation, and no P waves would conduct, but it certainly seems as if the P wave is conducting on these first, 10 beats or so. So it's not third degree, so it's some form of second degree heart block.
Second degree, yes.
So is it Mobitz 1 or is it Mobitz 2?
I would say Mobitz 2.
That's right. So in Mobitz 1, right, we would see progressive prolongation in the PR interval,
and then
a drop. So is Mobitz 2 typically thought to be at the level of the AV node or at the level of the His-Purkinje system? Typically, it's not a guarantee, but
if there's a P wave, but then I'd say a His-Purkinje system.
Yeah. So surgical heart block or is usually And Mobitz 2 is usually at the level of the His Purkinje system. Not always, but you would need a His catheter and an EP study to know for sure. But yes, usually this is some kind of His Purkinje disease. So this is some kind of Mobitz 2 heart block, second-degree heart block. And now the next question is, why would this happen in a stage 1 Norwood? Do you think? What part of the Norwood operation would cause this if it were to happen? I mean, what is a Norwood? Why don't we start with that, Mahmoud? What are we doing in a Norwood?
Okay. Let me remember.
Mm-hmm.
So
You can phone a friend if you'd like.
let me see. Is it okay if I saw an image just to explain it better?
I don't have an image available at this time.
No, I'll check it myself.
Okay. Well, in the interest of time, I think we should.
I'm there already.
Okay, good.
So basically, we will have the right ventricle. We will have a connection. No, I will ask a friend.
Okay, we're gonna phone a friend. Let's phone your friend Tarek Zawani.
Okay.
Dr. Zawani, what are the components of a stage 1 Norwood?
So the component of the stage 1 Norwood. So first, we make sure that there is adequate atrial communication. So usually septectomy, and then also we create a shunt between the innominate artery and then the pulmonary artery. And then lastly, it's the third component is going to depend on the aorta. So if we have adequate aorta, then we can use it. Otherwise, we will just make a DKS, which is like connection between the aorta and the very small aorta with the pulmonary artery, and that's what we will use for the systemic perfusion. And I think those are the components.
Well, so one thing I would so that was pretty good. One thing I would say is, I think as a general rule, when you're talking about a Norwood, we don't actually formally call the aortic arch reconstruction a DKS. That's a term used for another circumstance. It's a very similar operation, but it is not, I think, formally referred to as a Damas-K-Stanzel anastomosis. And the other thing I would say is that in some centers, of course, they do the Sano shunt from the RV to the PA, although at Mount Sinai, as you rightly said, we typically place a modified Blalock-Taussig shunt. It's generally a surgeon preference, and generally at the present time, when you look at like 5-year outcomes, it seems like they're almost identical in terms of survival. Although there is some evidence to suggest that early survival may be better with a Sano, although at long term, it seems like they kind of come out about the same. And as you know, there is some concern about placement of a shunt in the right ventricle of a single ventricle patient and the potential for arrhythmogenicity in the future, but that's not the purpose of this question. So of those, so now let's go back to Mahmoud. So Mahmoud, of those descriptions that Tarek just nicely outlined, which of those do you think would have been the most likely to potentially cause this problem that we're observing on this tracing?
I would say the reconstruction of the aorta.
Why would the reconstruction of the aorta have anything to do with the conduction system?
I think if there was some kind of manipulation or maneuver to the ventricular septum, that may affect the conduction system.
Okay, so does an aortic arch reconstruction have anything to do with?
No.
No, I don't remember Tarek mentioning VSD.
So I don't know.
Okay, that's a fair answer. I'll accept that. It's the atrial septectomy, right? Remember that the AV node lies in the triangle of Koch, which, let me see, I'll ask Grace Kong. Grace, what are the borders of the triangle of Koch?
It's the coronary sinus, the tricuspid valve leaflet,
Mhm.
and the third one is the crista terminalis.
No, good guess. Close.
Oh man.
That's the hardest one to remember. Let me see, is pernobonsal on the line?
Oh yes, the tendon of Totoro.
Yes, tendon of Totoro. So it's the mouth of the coronary sinus, the septal leaflet of the tricuspid valve, and the tendon of Totoro. So all those structures are very close to the atrial septum. So to some degree, it's really pretty miraculous that we don't see heart block more often with a wide atrial septectomy. And in fact, that's part of the reason why. Have you ever noticed that sometimes when you're echoing a hypoplast, the atrial septal defect that the surgeon has created is adequate, but it's not exactly gigantic, right? Sometimes we look at it and we're like, I guess it's okay, but it's not as big as I would, in a perfect world, I'd like to see it almost like a common atrium. And that's oftentimes intentional because the surgeon is trying to avoid causing heart block. And so they'll sometimes cheat and make the ASD a little bit smaller than in a perfect world you'd want to see, because they don't want to get anywhere near the triangle of Koch and potentially injure the node. So, okay, so Grace, what would we do if you observed this at night at 11:58 p.m. as this tracing suggests? What would you do?
I would put up a backup VVI pacer if this is not happening frequently. And then I would observe the patient for now. I'm sorry, did you say it's a post-op night one? Yes.
Up night one. Now, why are you putting a backup VVI? What do you think about VVI pacing in a patient who's just had a Norwood? So let's say this happens with some regularity, and we see this like maybe every page, we see 3 or 4 P waves that don't conduct, and you're VVI pacing. What do you think is going to happen to the hemodynamics to this type of patient? So we're at 11:58 p.m. Usually our hypoplast patients come back around 4:30, 5 o'clock. So at this point, the cardiac output should pretty much be at its absolute lowest, right? Because we're about 6 hours from a bypass run. So is VVI pacing the best way to, how important is it to have AV synchrony at this stage in this patient's post-op course, would you say?
I would say very important.
Very important, right. Now, and that's an important point, right? In the old days, like say 20 years ago or earlier, it was very unusual actually to have dual chamber pacing in either permanent or temporary, actually. In fact, the old temporary pacemakers did not even have atrial sensing as an option. So if you were going to dual chamber pace at a temporary bed space, you had to actually pace the atrium. So you would have to pace actually at a rate faster than the intrinsic atrial rate. There was no atrial sensing choice on the old ones. But my point is that we used to VVI pace people all the time, babies, and it generally worked very well. But we would not VVI pace somebody so soon after a big operation because the loss of AV synchrony in somebody who is already in low cardiac output could be very dangerous. This is one of the reasons, by the way, why I never liked this rule that they used to have in the ICU that you should check the threshold on the V, because you're basically asking people to cause hemodynamic embarrassment transiently while you're V pacing, because most people don't do it in a DDD mode when they're testing. So could you set this up in a dual chamber method to pace?
Yeah, I think so. If we can sense the A well.
Right, right. So you could just pace this patient DDD, right? And then only pace on the non-conducted P waves. So that would probably be a somewhat better hemodynamic result, I think. And let me go back to Mahmoud, since this is his question here. So the family is at the bedside. They see that you've just hooked up this pacemaker, and the mother is understandably concerned that her child is on a pacemaker. What are you going to tell her is the likelihood that this is going to need a permanent pacemaker on post-op night 1 where you're seeing this?
I wouldn't, I don't know a number, but I would say it's likely to resolve on its own.
Yes, well, the answer is that's correct. It's about 2/3 of the time conduction will recover. And the earlier you see it, the more likely it is that it will recover. If this were occurring on post-op night 8, we would be a little less confident, or a lot less confident. And the data suggests that if by post-operative day 8 or 9, you see something like this, only about 1 or 2% of the time will there be recovery of conduction. So this would be a very worrisome finding late after surgery, not as worrisome early after surgery, but definitely we would pace this patient and hope. Recently, I got an email from a colleague in Florida asking me if we ever use steroids in this circumstance, on the assumption that there is inflammation that is causing this. And I responded that we have never used steroids for this purpose. And to my knowledge, there's no evidence that it actually is effective in this setting. But people have talked about this. But I think that the potential benefits are outweighed by the potential risks in terms of infection and stuff like that. But I don't believe it's been studied in a rigorous manner. Okay, let's move on. So this was a tracing that was sent to me not too long ago. This is a former 34-week preemie. I was told that caffeine was recently removed or stopped or discontinued 3 days earlier. So this is an interesting tracing, and I will try to ask the fellow who did not ask me this. So I'm going to see if Dr. Bebbia, what do you think about this? Good morning. Happy to see you here, Dr. Bebbia.
Thank you. I'm happy to be here.
This is the toughest man of all time, was here right from the start, never missed a day. Impressive.
Thank you. But the toughest are actually there covering for me. Well, we see a very long sinus pause. I'll try to calculate how long it actually is. So it's 9 big boxes, 9.5, I would say.
How many seconds is that?
9.5 times 0.2, that would be, so it's about 2 seconds. Actually, no, it should be longer. Sorry. So 1 big box would be 200 milliseconds. So that would be around 5 seconds, I would say.
Well, it's
Am I wrong again?
It's more like 10 seconds we're looking at.
Okay.
So big long pause.
Big long pause, yes. And then we also have respiration and saturation. So this is a 34-week preemie who we know was on caffeine. So we assume that this baby had some apnea desaturations, which can also have bradycardia associated with that.
Mm-hmm.
If we look at the respiration, I wish I could see what was happening before, but I can see that that closer to the end of this sinus pause, we see some more kind of active breathing based on this respiratory line. So maybe this sinus pause was preceded by an apnea event, and the saturations during the sinus pause are also down.
I mean, I wouldn't read very much into that sat tracing. It looks pretty, I mean, it might be real, but it's pretty hard to interpret, right? Especially since there's not even a scale. And the person who sent me this tracing, Dr. Bonsall, wasn't kind enough to give me the numbers on the right-hand side of the screen, but I think we could surmise they weren't good.
So one explanation could be that because this is a preemie baby, this could have been apnea and desaturation and bradycardia.
Mhm.
And then other explanation would be some kind of abnormality in the sinus nodes, 6 sinus node.
Well, let me ask you, how often have we made that diagnosis in any patient?
Very rarely.
Baby, right? It's starting, you're starting to get to the point in your career where if you haven't seen it, it's not entirely true that it's never happened, but it's getting less common to be the case, right? So we don't really see sinus node dysfunction in newborns very often. Even newborns who've had complex congenital heart surgery usually have, at least transiently, have normal sinus node function. So I agree, this is probably just a typical apnea bradycardia type of event that you see in a preemie. The other thing is, I always wonder is whether there's reflux and a very high vagal tone in this setting. So what would you do about this? So the NICU wants to know, how would you treat this? Would you put a pacemaker in? Hello? Hello?
Sorry, I was muted. So I remember this patient from our service actually, and our idea was, since these pauses became more prominent after the caffeine was removed, we suggested to restarting the caffeine. And then in regards of regurgitation or reflux, I guess we can kind of adjust the feedings in a way that would not let the baby have more reflux.
Yeah,
I
guess
guess.
exactly right. So of course, the obvious is to just resume the caffeine, and sometimes in this circumstance, I'll just recommend empiric treatment with maybe famotidine or something like that to just see if it will make this problem go away. I believe it did get better after those interventions were performed. So it's an interesting tracing, scary looking, but all right. This is a 5-year-old. And the question is, what is the rhythm and what is the differential diagnosis? And I'm going to call upon Dr. Bonsall.
Good morning, Dr. Best.
Good morning, Colonel Bonsall.
I'm trying to look at P waves in 1. Not very certain, but they look positive in 2. From, what is it? Just give me one moment.
Please take your time.
Is here. I think P waves are, I'm trying to correlate from the rhythm strip in B1 to 3 and 2, and it looks upright in 2, 3, and AVF.
You think it's upright in AVF? I'm not convinced of that.
I'm trying to correlate with V1. Not very clear. Okay.
I mean, what is the heart rate, first of all?
The heart rate is the 300 divided by 1.5, so about 200.
Right. First question is, do you think it's likely that a 5-year-old who's lying down and getting a 12 lead is in sinus rhythm at close to? No.
And you're asking the question, so it's probably not.
Well, it's unlikely I'd be showing you a sinus rhythm ECG.
Yeah.
I have been devious in that manner. I understand, but I mean, I think you would agree. This is certainly not obviously sinus rhythm, right?
Mhm.
It's I
Yeah.
think you can spot sinus rhythm from across the room. This is not sinus rhythm. So
Yeah. If the ones that I think can lead one are P waves right after the T waves, I think those are inverted.
you're referring to this.
Yeah.
Okay.
Yeah. And then um and then if I follow that suit, then it is inverted in AVF also. And
Mhm.
2 is, yeah, 2 is inverted, 3 is inverted. I would say it's like a low atrial rhythm,
Okay.
or coming from an ectopic focus, and considering it's tachycardia, so I would call it EAT.
Okay, so that certainly is a very good potential diagnosis here. That it is EAT. Is there anything else that this could be?
It could be like long RP interval, so
Mhm.
it could be ORT.
Okay, now what is the RP interval normally in ORT?
More than 70 milliseconds.
Okay, so what would this RP roughly be in this case?
Mm, It's almost more than one big. It's almost one big box. So I would say 200 milliseconds.
Right, so it's almost 200 milliseconds.
Mhm.
Very long RP interval. So, so does ORT normally have an RP interval that's that long?
What did I seen? I've seen like close to when we've been doing EP studies, like 150 milliseconds and stuff.
Yeah, that's
200 is too long for that.
200's a little long, right?
PJRT is another differential with a
Right,
long RP interval.
right. So this could be PJRT also, exactly. And if you're in the emergency department and you're seeing this patient, how could you determine the difference between them? How would you know which of these this is? And that would be the correct differential. When you see such a, so just so we take a step back, when we say a
Mhm.
long RP tachycardia, you know, where what is usually meant when somebody says a long RP tachycardia is they mean an RP interval that is like this, like greater than 150 to 200 milliseconds. You're thinking about it in terms of what I've explained to you, which is that in AVNRT, the RP interval is less than 70 milliseconds, and in ORT, it's greater than 70 milliseconds. But that is not generally what is thought of as a long RP interval. Long RP is like this. It's like an RP interval of about 200 milliseconds or greater. So, so the differential is just as you said, EAT or PJRT. It also could be some form of atrial flutter, right? You could have atrial flutter with one, although again, it's this patient has a structurally normal heart, so it'd be a little unusual to have atrial flutter at 5 years of age. So how could you, if you're at the bedside, how would you just differentiate those two, do you think?
We could give adenosine, and
Right.
that would block at the AV node.
Okay, and what would happen if it were ectopic atrial tachycardia and you gave adenosine?
It will not work.
Well, what do you mean by that?
Like you would not see slowing of the heart rate.
I disagree with that. What would happen to the AV node if you were in EAT and you gave adenosine?
I
What
mean,
happened to the ventricular rate?
your AB node would block, so you would actually see more P waves.
Right. So you would block the AV node and you would potentially see persistence of the atrial tachycardia. So your ventricular rate would fall transiently. Your atrial rate would potentially stay the same, right?
Yeah.
Okay, and what would happen if you gave adenosine to somebody who had PJRT?
You would still conduct because you could conduct through your accessory pathway.
Right, but what would happen? Would tachycardia persist or would it break? What is the loop in PJRT? How do we go from atrium to ventricle, and how do we go from ventricle to atrium?
So it's a form of ABRT. PJRT is a form of ABRT.
Mm-hmm.
So you go from atria to AV node in the ventricle, and then you go back from the accessory pathway through the AV node and come back
Wait,
to
what do you
the
mean back?
ventricle.
What do you mean back through the AV node? You just came down through the AV node.
And then you come back, like you form a loop around, you go back to AV node and then come back to the ventricle.
Wait. I just, we're skipping a step. So you're going from the atrium to the ventricle through the AV node. I agree with that. And then how do we go from the ventricle back up to the atrium in PJRT?
Through the accessory pathway.
Right, okay, you kept throwing that word AV node in there. I wasn't sure what that meant. Right, so what is different about a PJRT accessory pathway in comparison with a typical pathway in orthodromic reentrant tachycardia? What's the main characteristic that is different between those two?
Main characteristic.
What about its conduction times? How do they differ between ORT and a PJRT pathway?
I mean, since we said the RP interval is longer in PJRT,
Mm-hmm.
so then it should be slower in terms of
Conduction.
conduction.
That's exactly right. PJRT pathways generally conduct much slower than pathways in ORT. And that's in fact why people with PJRT, that's where the P of PJRT comes from, permanent. Of course, it's not permanent, but it seems permanent. So when we have ORT, right, we go down the AV node and up the accessory pathway and then back down. And one of the questions that always comes up is, why are we not in ORT all the time? The reason we're not in ORT all the time, of course, is because the retrograde conduction is so rapid that the atrium is still refractory from the sinus beat before. So in sinus rhythm, you depolarize the atrium, you go down the AV node, and in anyone who has an accessory pathway, there is always conduction retrograde through the pathway. But you do not go back into ORT because the atrium is still refractory from the prior sinus beat because the conduction retrograde is so quick through the accessory pathway. However, if you have PJRT, the pathway's characteristics are such, as you just explained, that it conducts very slowly. And so paradoxically, even though it conducts slowly, it allows you to have tachycardia because if it conducts slowly enough, by the time the impulse goes from the V to the A, the atrium will no longer be refractory and it will depolarize from that retrograde impulse, and then you'll be back in tachycardia. So you're in a slow form of tachycardia. And so if you were to give adenosine to such a patient, you would see termination of tachycardia, but the likelihood is high that it would resume almost immediately after the AV block is gone from the adenosine. So this highlights one of the reasons why when you're giving adenosine to anybody in tachycardia, you always want to run the electrocardiographic rhythm strip at the same time, because oftentimes in real time, the tachycardia termination may be so brief that you won't notice it because you go right back into tachycardia. But if you were to see a pause in tachycardia, it would be very suggestive that the patient does have PJRT. The only thing I would say is everything you said is 100% correct, Perna, but if you give adenosine to someone with EAT, occasionally some EATs will terminate with adenosine. So that rule makes it a little bit harder. In this particular case, this patient actually did have EAT, and this electrocardiogram was obtained in the recovery room prior to the ablation on that patient. And I think next week, we'll review that case and how we mapped and ablated this arrhythmia, which in fact was coming from the left atrium. So I think with that, we'll stop. Does anybody have any questions before we end today's conference?
Yes, Dr. So how will you distinguish between flutter and EAT when you give adenosine?
That's a good question. It would be hard to tell, actually, but again, I think the most important way I would say is, one way would be this thing that I just mentioned, which is that oftentimes, a lot of times EAT will transiently terminate, whereas flutter would not. And then I think a lot of it has to do with epidemiology. 5-year-olds with structurally normal hearts, I'm not sure I've ever seen atrial flutter in a 5-year-old who has a structurally normal heart. So it would be, you know, the other ways to do it would have to be in the EP lab. So we could pace terminate and start it, which would be a little unusual for EAT or not as common. There are other pacing maneuvers we could do to try and distinguish between the two. Also, creating a activation map, we would be able to see reentry more obviously with CARTO, and that would make it more obvious versus an activation map from EAT where there would be a single focus from which the rhythm was originating. And I'll see if I can get some CARTO images on this case so that we can review it next week. It was an interesting case. So any other questions at this time? All right, I hope everybody has a great day. Thank you for coming today, and I'll see you at Sign Out in just a short while.
Thank you.
Thank you.